ورجعنا لكم تاني في برنامجكم بودكاست بالسكر. انا بكلمكم انا هاني نعيم، بكلمكم من روما، من مؤتمر النيو دعاب، مؤتمر الجمعيه الاوروبيه لالتهاب الجهاز السكري. ويسعدني ان انا يكون معايا النهارده استاذ الاساتذه، استاذي اللي بحبه وبحترمه وعلمني كتير، وبفتخر ان انا احد مريديه وتلامذته، الاستاذ الدكتور بول فالنسي من جامعه باريس في فرنسا. Good morning, professor.
Good morning, Henny.
Will you please introduce yourself to your Egyptian spectators?
Yes. So, good morning, everybody. My name is Paul Valenci. I'm a professor of nutrition in Paris North University. I'm an endocrinologist, diabetologist. I'm also a cardiologist. And so I'm particularly involved in the cardiovascular and neurovascular complications of diabetes and also of obesity.
Okay, can we say it a bit easier? So you are a professor of medicine at University of Paris, and you are an endocrinologist, which is a doctor who deals with hormones. You are a diabetologist, a doctor which deals with diabetes, cardiologist, a doctor which deals with the heart,
Yes.
and a doctor who deals with obesity.
Yes.
And your main field of interest is in diabetic neuropathy and the heart.
Yes, that's true.
Am I correct?
Yes. Very good.
Okay, wonderful. Okay, so would you like to tell me about your the research you have presented here?
Mhm. Yes. So here in this meeting, which gathers experts of diabetic neuropathy, I talked about the apnea syndrome, which is a complication or disease associated with obesity and with diabetes.
Okay.
So
Which is the disease where the patient stops breathing
stop
while
during
he's
the
asleep.
night. And when these apneas, which means stop breathing,
Mhm.
are numerous, we call that an apnea syndrome.
Mhm.
And apnea syndrome is associated with more cardiovascular disease.
Okay.
And also, what we showed here is the association between apnea syndrome and dysautonomia, alteration of the autonomic nervous system.
Mhm.
So, in fact, we have to define what
Yes.
is this system and which may be the different kinds of impairment in diabetes and in obesity.
Okay, so this autonomic neuropathy is where the nervous system, which does not control the muscles, which makes us move, and does not carry the sensation, which makes us feel. This is the system which controls things like the heart, how fast your gut is growing, your intestines, how fast they're growing, how fast you're breathing, if you're sweating or not.
Yes.
All of this is controlled by the autonomic nervous system. And Professor Valencia has demonstrated a link between obstructive sleep apnea and the autonomic neuropathy. What have you shown specifically in this
Yes.
conference?
So what you just mentioned refers to the complications of diabetes, which indeed may impact on the heart, on the intestine, on the bladder, and other organs.
Mhm.
So this may be very important with various signs and symptoms which a patient complain of.
Mhm.
This is a severe disease. And what I examined is an earlier step of this disorder, earlier step. What may happen at these earlier steps? What may happen is some trend to a tachycardia, high heart
Tachycardia
rate,
is, yes, the heart beats fast.
fast.
Mhm.
And this may be due to vagal impairment. So
Okay, this is the
defect
nerve which controls the heart.
heart, and
Okay.
sympathetic hyperactivity, the other system. So we have on the heart a balance between vagal, which is rather good, and sympathetic, which is rather bad.
Mhm.
And in these patients with apnea syndrome, we have too many patients with slight increase in sympathetic activity and vagal defect. So this imbalance is more marked in the obese or diabetic patients who have these symptoms called apnea syndrome.
Mm-hmm. Okay. And you found that people who have obstructive sleep apnea have a higher heart rate.
Yes, a trend to an increase in heart rate, because this is simple to tell
Mhm.
about, but in fact it's more difficult. We have to dissect heart rate variations. But heart rate variations are impaired, meaning that vagal activity, so relaxing branch of the autonomic system,
Mhm.
is impaired.
Okay. So from this, what can we tell the people? So you have found this defect.
Mhm.
Okay. What should people do about it?
Yes. So it's interesting and useful to detect this syndrome in
Mhm.
patients with obesity and with diabetes. We have questions for that, questionnaires. People, for instance, complain of being sleepy during the day, being tired, having bad sleep during the
Mhm.
night, too much snoring,
Mhm.
raising in the morning already tired, and all other symptoms.
Okay.
And
So we should first find who has obstructive sleep apnea.
okay,
Okay.
so we make a polygraphy to record.
Polysomnography. So we make a sleep
polysomnography.
study.
Yes, and
Okay.
the sleep study confirms or doesn't confirm the presence of the apnea syndrome.
Okay.
Now, when the apnea syndrome is there, what to do with that?
Mm-hmm.
Of course, we can investigate the autonomic system, as
Yes.
I mentioned. We can investigate the consequences of this apnea syndrome, which are first, elevation of blood pressure. Hypertension is favored also by the apnea syndrome.
How high does obstructive sleep apnea increase the blood pressure of a person
Difficult to say, but it's
on average?
it may be an average of 5 or 10 millimeters of mercury for the systolic blood pressure.
Okay.
But importantly, there is an increase in nocturnal blood pressure.
So this is a very important point.
Hmm.
What difference does it make if the person's blood pressure increases during the day or when he's asleep at night?
Yes. What happens during the night, normal people lower their blood pressure during the night. And there is an increase occurring when you awake in the morning, even early at 5 or 6 a.m. And in fact, in these patients with apnea syndrome, blood pressure becomes stable over 24 hours. It means the same during the night and during
So
the
we
day.
do not lose. We lose the what we call the morning dip,
The dipping.
which is blood pressure goes down for a while and then
Yes.
comes up, which is the morning surge.
Yes.
Okay.
And even in some patients, blood pressure becomes higher during the night than during the day.
Which is nocturnal surge.
Yes.
What difference does it make to know if the blood pressure increases at night or not?
So it increases during the night and during morning surge. This increases the risk of stroke.
Okay. So you can actually have a stroke, okay, which is a blood clot in the brain,
Mhm.
if your blood pressure does not decrease while you are sleeping. Okay. Now, obstructive sleep apnea causes the loss of this protective nocturnal dip or nocturnal low blood pressure.
Yes.
Okay. So when I find obstructive sleep apnea, I should investigate for the
Yes.
presence or absence of nocturnal dip using 24-hour ambulatory blood
Yes.
pressure.
Yes.
Okay.
Yes.
And if I find this patient has lost his nocturnal low blood pressure, what should I do next?
So the syndrome is there. This complication of obesity and diabetes is there. What to do? There is a very strong correlation between apnea syndrome and body weight.
Okay.
So patients who are able to lose, let's say, 8 or 10% of their body weight will improve the apnea syndrome.
Wonderful. So first thing is I encourage the person to lose body weight.
Yes.
You know, this is much easier said than done.
Yes.
Okay. So, and it will not happen tonight. it will take
It takes
a
time,
lot of time.
and it requires efforts for everybody, and it requires effort on the long term. That means you will lose weight, and you need to
Sustain
sustain it for long term.
Okay.
This will improve the apnea syndrome.
Okay.
This will improve blood pressure profile during the day and the
Mhm.
night.
Now, I wanted to ask you, until he loses this weight, is there anything else we can do?
What we can do, of course, is to treat the apnea syndrome. There is a system called CPAP,
Okay.
which means high pressure of
Continuous
air flow
positive airway
during the
pressure.
night.
Okay.
During the
So
night.
we can use the CPAP. Anything else we can do? How about reducing his blood pressure first?
Yes, reducing blood pressure and reestablish
Okay.
24-hour changes.
So first thing is I give treatment, and then after I give treatment, I should repeat the 24-hour blood pressure
Yeah.
to make sure it has actually worked. Because I may have a morning good blood pressure and then evening bad blood pressure.
Absolutely.
It can happen.
So this may need several antihypertensive drugs.
Mm-hmm.
You have to manage that and to measure by yourself.
Mm-hmm.
Also control the other risk factors, of course,
Like
because
lipids, cholesterol.
Yes, blood
sugar.
glucose, sugar, and lipids. And why to do that? Because in fact, patients with apnea syndrome are at higher risk.
Mm-hmm.
In addition to diabetes, in addition to obesity, in addition to hypertension, apnea syndrome adds a particular risk, cardiovascular risk.
Okay. I wanted to ask you about, is there any form of research which you have done in the past which you would like to tell us about?
Yes, maybe related
Because
to
you
this.
have done so much. How many papers have you published?
Nearly 400. Yeah.
See?
Which are quoted and others which are not quoted, of course.
Okay.
Well, so I'm interested in particular in silent coronary disease and silent heart failure. This means silent heart disease,
Mm-hmm.
and this means that in particular patients with diabetes are lacking symptoms, do not complain of any sign, and in fact, disease is running in silence.
Mm.
So what does it mean, for instance? Diabetic patients with other risk factors or with nephropathy or with...
Nephropathy is disease of the kidney caused by diabetes.
Yes, or with peripheral artery disease.
Okay, this is clogging or obstruction or atherosclerosis of the blood, the arteries, vessels going to
Yes.
the legs.
So these patients are at high risk of having coronary disease, even without complaining of any pain.
Mm-hmm.
So coronary disease is running in silence. So how to detect it? We can do several kinds of examinations. You go to the cardiologist. First, you will have a standard ECG,
Mm-hmm.
which is usual to
Is
do.
having a normal standard ECG enough to tell the person there's nothing wrong with you?
Yes, it may ECG sometimes.
It's enough?
No, not enough.
Not enough.
But
Yes.
it may already detect.
If I find something, then it's there. Okay,
Yes.
that's it. But what if it's normal? Does this mean this person is normal? He doesn't
Yes.
have any problems?
No, it doesn't mean this person is normal. We need to go further in some patients with other risk factors, as I mentioned.
So first thing, we see the person and we do a standard ECG, which is wonderful. It's first step. It's cheap. It's available. It's everywhere.
Absolutely.
And we look at it. If there's something there, then we know for sure something is wrong, and we can proceed with our investigations
Mhm.
up to coronary stenting or even an operation or whatever. It's not our story now. But if he has a normal ECG
Yes.
and this person is of high risk, like for example, at my center, we do autonomic testing, cardiac autonomic neuropathy testing for everyone. If I find cardiac autonomic
Yes.
nerve problem,
Yes.
should I proceed with
Yes.
more tests?
Cardiac autonomic alterations, in addition to other risk factors
Mm-hmm.
elevate the coronary risk. I will not say absolutely that cardiac neuropathy alone is enough to define a high risk. But in addition to hypercholesterolemia, to hypertension, in addition to kidney disease, the risk of coronary disease becomes very high.
Okay.
And in this case, we have to move forward to
Mhm.
other examinations.
Okay. What other examinations can we do?
So we suggest in French position, we suggest to perform a coronary artery calcium score.
Would you do coronary artery calcium score is a test done with the CT
CT scan without
without
injection,
contrast?
non-invasive
Okay.
examination.
Would you do it first, or would you do an echocardiography first, or would you order them both?
Yes,
I'm asking for your opinion.
yes. About echo, it's certainly interesting. If we perform echo to 100 patients with diabetes, we will find several with abnormalities. The question is, what does it mean?
Okay.
Silent heart failure, maybe in some cases we can detect it.
Okay.
Anyway, if you go to the cardiologist, he will do ECG, and very often he will also do a kind of
Echocardiography.
echoscopy. Yeah.
Okay. And now, can diabetes and autonomic neuropathy cause heart failure?
Yes, autonomic neuropathy also is a contributor to heart failure.
And we said also that obstructive sleep apnea contributes.
Also is a contributor to heart failure. So we have a connection of all these factors, and ideally, we should be able, as doctors, to evaluate the risk of coronary disease and
Mhm.
also the risk for heart failure.
Okay. So, in order to evaluate this risk, when I see a patient, I should first assess his glucose status using his blood sugars and his hemoglobin A1C. I should assess his heart using an ECG.
Mhm.
I should assess his blood pressure in different positions. Maybe I should test for his ankle brachial index, his ABI, to make sure he doesn't have peripheral artery disease. I should assess clinically for neuropathy. I may assess him for cardiac autonomic neuropathy,
Mhm.
okay, using various methods. And then after this, I should ask for laboratory tests. I should do questionnaires in order to see if he is high risk for obstructive sleep apnea, for example,
Yeah.
or any other disease. And then we should order blood tests. Is there a blood test which can tell me if the person has heart failure?
Yes. Measuring NT-proBNP in the serum is very
And the blood-
reliable
It's very reliable.
and early marker for heart failure.
Okay. Now, when I measure the NT-proBNP, let's say it's not that high.
Mhm.
Does this say that this person does not have heart failure?
Yes, we can accept that.
We can
Under
accept this.
over 125 means risk of heart failure. It doesn't mean
Okay.
heart failure, risk of heart failure.
Okay. And can someone have heart failure and have a good ejection fraction on echocardiography?
Yes.
Okay. Well, there's a name for it.
Yes, the name is heart failure with preserved ejection fractions, which represent probably at least 50% of the population with diabetes and obesity.
Okay. Now we know that this person can have heart failure with a normal echo or with an abnormal echo.
Yes.
I mean, as an ejection fraction,
Mhm.
because there are changes with
Yes.
heart failure with preserved ejection fraction. Is there a treatment for this?
Very difficult. And even cardiologists, not all cardiologists are really convinced about these alterations of, let's say, relaxation function of the left ventricle. It's very difficult to define.
But there are
When the
medicines which help.
Yes, but if the patient has symptoms of heart failure, we have to define who has low and who has preserved ejection fraction.
Okay.
But in a patient without symptoms, it's very difficult to say, well, here have some kind of alteration of diastolic relaxation function, and this means a risk of heart failure. I need to intensify the treatment and do so and so. Even all cardiologists are not really convinced.
Okay, now there was a very nice study which came out on semaglutide, a drug, which is one of the injections for blood sugar which people are using to lose weight, on heart failure. If you remember, it was a few months ago.
Yes,
Okay.
STEP HF.
Yeah. What do you think about it?
It's a wonderful study, wonderful study.
Is
So
it,
it was performed first in obese patients with heart failure, this means with signs of heart failure, but preserved ejection fraction, without diabetes. And second limb of the study, the same plus diabetes. And both studies say the same thing. When using semaglutide at high dosage, 2.4 milligrams once weekly, this means a dosage we use in obesity, not for diabetes, in obesity. In this case, the patient may lose 8% of body weight if they are diabetic, 15% of body weight if they are not diabetic, so they lose a lot of weight and they maintain the result during the long term, and at the same time, they improve their physical capacity.
Okay.
So very interesting.
Which means that they can now go up the stairs without being breathless.
Yes, absolutely. So this means this is certainly favorable for the prognosis. But, well, if we analyze correctly, finally, altogether, this data of studies performed with semaglutide high dosage, we can show this efficacy in the prevention of heart failure events.
Okay. I can't thank you enough. If we go quickly through what we talked about today, first, really blessed to be with you today, dear professor, my professor.
Yes.
Okay. And second, you talked about the relationship between the heart and obstructive sleep apnea, which is a hot topic. Many of us are talking about it at this conference.
Yes.
Okay, we talked about autonomic neuropathy and its effect on the heart, obstructive sleep apnea and its effect on blood pressure, obstructive sleep apnea and its effect on heart failure, and autonomic neuropathy as a risk factor for coronary artery disease. And then we went a bit through the investigations, and then we went through a bit through the medications. And I am very thankful for you agreeing to be my guest in this podcast.
Thank you for the invitation. It was a pleasure having this discussion, but only unilateral discussion.
Okay. One more thing: is there something you'd like to say to the people of Egypt?
Yes, it will be a pleasure to meet again with Egyptian doctors and maybe patients in the future. Probably we have a lot to do to improve, I would say, general disease management, and this may be done with doctors, and this is also done by patients themselves or herself.
Thank you, Professor. Thank you so much.
Thank you.
Thank you. Bye-bye.